Okay, well, welcome everybody. So we'll get started here today. So welcome to Chasing Z's, Sleep Issues and Parkinson's with Dr. Joza. My name's Bree, and I work in client services here with Parkinson's Association of Alberta, and I'll be moderating the webinar this morning. If you have any questions during the webinar, you can submit them in the chat there at the bottom on the left, or kind of in the middle-ish, and there's a little chat icon, and you can type your questions in there as we go. And yeah, I'll help ask questions of Dr. Joza when we get towards the end of the presentation there, with a little chance for some Q&A time. I do want to say that this webinar is being recorded, and all information provided in this video by Parkinson's Association and our featured speaker is strictly for educational and entertainment purposes only. It's not intended to be diagnostic, prescriptive, or replace the relationship, advice, and/or care of your physician. So general questions about the symptoms and other kind of related stuff to sleep will be fielded today. So yeah, to introduce Dr. Joza, so he earned a PhD in laboratory medicine and pathobiology from the University of Toronto in 2012 and a medical degree from Queen's University in 2016. He completed his residency in adult neurology at the University of Alberta in 2021, followed by clinical and research fellowship in movement disorders as an Edmund J. Safra Fellow at the Montreal Neurological Institute and a clinical fellowship in sleep neurology at the University of Toronto. He had joined the Parkinson's and Movement Disorders Program and Sleep Medicine Program in 2024 and is currently Assistant Professor of Medicine at the University of Alberta. His research focuses on the prodromal stages of Parkinson's disease, including the progression of clinical, psychological, and neuroimaging biomarkers in patients with REM sleep behavior disorder as they progress towards overt disease, like Parkinson's disease, Lewy body dementia, and multiple systems atrophy. He's also interested in the remote monitoring and diagnosis of sleep disorders. So welcome, Dr. Joza. Thank you for joining us today.
Yes, thank you so much. I'm very happy to be here, and thank you again for the opportunity to speak about sleep and Parkinson's disease. Um, I often tell people that I'm a bit of an accidental sleep neurologist. My interest in sleep actually stemmed from my original interest in Parkinson's disease and especially REM sleep behavior disorder. That disorder that's probably familiar to most listeners here about people who act out their dreams. And because of my interest in both Parkinson's disease as well as this entity REM sleep behavior disorder, I undertook some additional training in sleep, and that's kind of how I became an accidental sleep neurologist. Again, as I joke. Hopefully, there'll be plenty of time for questions because I think that might be a little more interactive and helpful, I think, for many people. But I'll definitely go over everything that I have in my slides, which I think will be of interest. I have no relevant disclosures, financial or otherwise. It's a bit of an outline of the talk. I'll talk about just a brief overview of some of the motor symptoms of Parkinson's disease because these are the ones that are most obvious to people. But probably of more relevance, certainly to this crowd, are the non-motor symptoms, of which sleep is a very prominent non-motor issue in Parkinson's. And sleep disorders in particular will go over what are the problems of sleep that people with Parkinson's disease experience. What are some of the what effect do some of the symptoms of Parkinson's disease, medications, and other health problems have on sleep, and then learn about ways that we can try to manage our sleep better, particularly as it relates to people with Parkinson's disease. I'll just very briefly mention, and many people might already know as well, that Parkinson's disease was originally described as the shaking palsy. This was over 200 years ago in 1817 by Dr. James Parkinson. And he wrote an essay on the shaking palsy where he very beautifully and vividly described the patients that he observed who had this new, at the time, a newly described disease that ultimately would bear his name of Parkinson's disease. It's a very beautiful read, very actually pretty accessible read if you ever want to look it up. But the thing that he made so many astute observations about the non-motor features of the disease, and one of them included sleep. And again, he describes it thusly that in this stage, the sleep becomes much disturbed. The tremulous motion of the limbs occur during sleep and augment until they awaken the patient, and frequently with much agitation and alarm. Very, again, beautifully written, very poetic, and very vividly described. So it is to say that sleep issues have certainly were certainly described even from the original paper over 200 years ago. The one thing though that's interesting for me is that when he says in this stage, he's actually referring to the late stages of Parkinson's disease. And so for a long time, it was thought that non-motor issues like sleep were more of a later presentation of the disease rather than something being up front. And we know this actually isn't quite the case. The reasons why this might be is that when we think of Parkinson's disease, most people consider the motor symptoms of Parkinson's or the motor features of Parkinson's. For example, there's the resting tremors is what we often see, and that's what pretty much everyone thinks about. Many people will say, that they can't possibly have Parkinson's disease because they don't really have a tremor. And we know that's not entirely true in many cases. The other motor feature of significance is bradykinesia. That basically just means slowed movement, and that's really one of the most important motor symptoms that we see in Parkinson's disease. It's a very early symptom, and it can present itself in many different ways. But many people will describe hand slowness or clumsiness, a perception that the hand, for example, feels weak, but really it's more of a question of slowness. Might develop small handwriting, the voice, the vocal cords being influenced by muscles and such, they also start to slow down and the voice can get quiet, the walking gets slower, the person might start to shuffle. And then rigidity is the other classic motor feature of Parkinson's disease. Postural changes, stoop posture and imbalance sort of round things out for many people, although it might not be an upfront symptom for many. And in fact, these classic motor symptoms are really literally how we define the disease. I often tell people that there's no fancy brain scan or fancy test as yet that is completely diagnostic for Parkinson's disease. The way that we define Parkinsonism is our observations of these basic elements, slowness of movement or bradykinesia, and at least one element of either rigidity and or rest tremor. And so that's how we define Parkinsonism, purely based on motor features. When we actually look at the pathology, and that usually means looking under a microscope or something along those sorts of lines. Much of what we sort of focused on originally when the disease was first being learned about over the last couple centuries was we looked at an area of the brain called the midbrain. Here's just a regular MRI scan that you might see, and this is a normal looking midbrain. If you actually take the midbrain out in people who have died after they have having had Parkinson's disease, what we notice is that I'm not sure actually if my mouse is pointing or not. I hope it is because it is on my screen. But what we end up seeing is that in this
Yes.
area here, yep.
Yeah.
Yep. In this area of the midbrain here called the substantia nigra, we see that there's a loss of dopamine producing cells. This is a very healthy looking, this is a person who died who was healthy or did not have Parkinson's disease. And we see that there's a lot of this area here are the normal dopamine producing cells. But then people with Parkinson's, for reasons we don't 100% understand, those dopamine producing cells are lost in this area of the brain called the substantia nigra. And in fact, if we take pieces of the brain and we really zoom in under a microscope, what we see are these Lewy bodies. Again, Lewy body is probably a term that's very familiar to many people, but this is actually what it looks like if you look at it under a microscope. This is a neuron within the brain that contains these abnormal aggregates of this protein. Now, the main constituent of which is called synuclein. And so we can look under a microscope and we can actually see that in these areas where we see a lot of damage, we see that the neurons themselves are being damaged. We think in part due to an accumulation of this abnormal protein called synuclein, which forms this thing called a Lewy body. Now, the the one sort of element that became important, just going back just for a second, was that it was originally very hard to find these Lewy bodies under a microscope. We didn't up until actually the mid 90s, they sort of had to be looked at carefully by eye. But in the 1990s, they finally actually were able to figure out what this abnormal protein was, and then therefore figured out ways that you could actually mark and tag these areas under a microscope, making them much, much more easier to find. And when they discovered that, they started to notice that alpha-synuclein, far from being just seen in that area of the brain that controls motor function, the midbrain that we were just looking at, it actually can be found throughout the body in many, many, many different tissues, not just the ones that necessarily control motor function. So one very important concept that we have, this concept of the BRAC stages of neurodegeneration, is actually a concept that's now over 20 years old, but it's pretty useful. And there are many different sort of variations surrounding this model. But the basic idea is that Parkinson's disease, this abnormal accumulation of alpha-synuclein, or these abnormal Lewy bodies, have to start somewhere. And for many people, not everybody, but for many people, this often can start more in the periphery, outside of the actual brain itself. And in the very, very early stages of the disease, it's a matter of these abnormal proteins starting peripherally and then sort of marching, advancing upwards, affecting different parts of the brain, ultimately spreading. So, for example, in the very, very early stages of the disease, various peripheral nerves, for example, the dorsal motor nucleus of the vagus nerve, or the olfactory bulb. So the olfactory bulb is where we get our sense of smell. The dorsal motor nucleus of the vagus nerve controls a whole host of different functions of the body. But that's where we think, at least in part, where the Parkinson's disease starts and actually begins to spread. As you get into further stages, as the disease sort of progresses upwards to involve more parts of the brain, for example, in stage 2, that's actually where we start to see actual dysfunctions. Autonomic function are things that control stuff like blood pressure and heart rate, and we know that those can be affected very early in the very earliest of stages of Parkinson's disease, before a person ever develops a tremor or slowness of movement. Sleep dysregulation is also such a fundamental feature of our brains. That it can be affected very early on in the disease course, olfactory or smell deficits as well. And it's really only as the disease continues to march up, sort of relentlessly spreading over time, that we actually start to develop the very hint of onset of motor symptoms. And it's really more into stage 4 when actually the areas of the brain, like the midbrain, start to really become involved, that you get the core features of bradykinesia, slowed movement, resting tremor, that are the obvious motor forms of Parkinson's disease. Of course, there might be later stages 5 and 6 when people start to actually develop more cognitive issues. Again, I want to stress that this is a model that's not necessarily completely accurate and might not describe everybody who develops Parkinson's disease. But you can sort of understand why motor features are the most prominent sorts of features of Parkinson's disease that we see, and why all of these non-motor features, including sleep, were sort of relegated to the side, because it was simply something that we just didn't notice until we started to understand how Parkinson's disease starts and how it sort of spreads over time. Here's maybe a different way of looking at the same sort of concept. The basic idea being that in prodromal states of Parkinson's disease, that's prodromal in this case being before a person develops that resting tremor or that slowness of movement, those motor features, there's a whole host of non-motor symptoms that are initially involved. And only as the disease progresses do you actually start to get the actual motor features of Parkinson's disease. And yet the non-motor symptoms are so prominent and actually start to become the bigger problem in most cases. So just to sum up again, that Parkinson's disease is not just a motor problem. The issue is that many of the motor problems are related to lack of dopamine, and so the corollary to that is that giving people dopamine often fixes these motor problems. And certainly in the early and mid stages, we can give pills or patches that boost the levels of dopamine. Later stages of motor Parkinson's disease with more significant motor disabilities, like a lot of off time or a lot of dyskinesias, or things of that nature sometimes can be helped by advanced therapies like surgery, DBS or duodopa or what have you. And so most of these motor issues, at least we have a reasonably good way of treating them. Give more dopamine because that seems to work. Unfortunately, all of these non-motor symptoms often do not respond to dopamine. And these are all of the non-motor areas of the brain, um, which we'll get into just after this. So with that sort of basic overview of motor features of Parkinson's disease, non-motor features of Parkinson's disease, we'll delve now we'll delve more or much more into sleep. I'll just talk a little bit about the basics of sleep itself. The one key sort of thing is in sleep research and sleep medicine is the fact that sleep is an active system. This is not a sort of passive thing. The brain controls very actively whether you're awake or asleep. It's not just a question of the brain just deciding to completely shut down, and that leads to a lack of consciousness. There's actually active areas of the brain that are signaling signaling either promoting wakefulness or promoting sleep. You know, for example, in this first part here, these are a whole bunch of different circuits involving a whole bunch of different neurotransmitters like dopamine or serotonin or acetylcholine. These are all areas of the brain as we currently understand them that promote wakefulness. And you see that there's a whole host of related and different parts of the brain that form circuits that are actively promoting sleep, either non-REM sleep or REM sleep. You can sort of tag them together. But the key message that I'm trying to make here is the fact that sleep is an active process. Certain parts of the brain promote wakefulness, certain parts of the brain promote sleep, and they sort of work together to keep you into one state or another, or at least that's how it should normally work. Sleep and wake, we conceptually think of being driven by two main circuits. One's a circadian system. So that circadian means means about, dia means day, so about a day, so circadian rhythms. And the other is the homeostatic system. You can think of homeostatic like a thermostat. That's kind of how we sort of think of it. If we sort of look at these two concepts separately, the circadian system, we often sort of abbreviate as process C. Yeah, for example, if we look sort of over a 2-day course between 7 a.m., 7 a.m., 7 a.m., so over a 48-hour sort of period, the normal circadian rhythm follows this sort of sinusoidal up and down pattern. And we often think of this as the wake drive. The circadian system has a clock that, just like any other clock, oscillates over time. That's how we sort of keep track of things. And we synchronize it mostly by light exposure. There's other things that sort of synchronize the clock, but that's a basic principle. So everyone's brain has an internal clock that has this sort of sinusoidal pattern that promotes wakefulness at certain times, and at other times when it's less active, contributes to developing sleep. The secondary system is we call process S, or homeostatic system, and this as a concept we think more of as sleep pressure. So the longer that one stays awake, there's more accumulation of process S that accumulates and drives promotion of sleep. As soon as you go to sleep, that it falls up sharply. As soon as you go awake, it starts to build up and up and up and up again. And so if we combine these two forces together, process C that promotes wakefulness, process S that promotes sleepiness, we see that they sort of work together in tandem. At least that's normally how they should work. So early on in the daytime, as a person has just woken up, process C is revving up, keeping that person alert. Process S is as low as it can be because you just had a full night of sleep. And so the wakefulness, there's a strong urge to wake. Conversely, as the day goes on, process S, the amount of sleep drive increases and accumulates. And process C, the sort of wakefulness promoter drops off as it naturally should. And once you get this large gap in between the two, the process S takes over and the person falls asleep, only for the process to restart over again. And so there are these two opposing forces, again, conceptually, that we think about that promote sleep and wake. The key thing is returning to the schematic, is that both of these circuits, the circadian circuit, the homeostatic circuit, both of these are affected by Parkinson's disease pathology, and it's not too hard to see why. Looking again at how we think or how we conceive of synuclein and Lewy bodies spreading early in the disease and marching up the brainstem and invading other parts of the brain, you see that all of these circuits have the potential to be involved. And so people with Parkinson's disease have a disruption in both of these circuits. Now, to what extent is very much would depend on the individual, but as a sort of a concept, this is why we see these problems. Looking at as well as the actual ultrastructure of the sleep itself is actually a little bit interesting to look at. This is called a hypnogram, and what this shows is the various stages that a person will undergo during sleep. We again conceptually divide sleep as either being REM sleep, that's where we do most of our heavy dreaming, or vivid dreaming, and non-REM sleep. And these are two different types of sleep, and we theorize that they have very different purposes. But the basic sort of thing that should normally happen in a sleep cycle is that a person starts off awake at the very start of the night, and then after a few minutes or so, they drop off into different parts of sleep. This goes into a very specific pattern. It should normally be going from wake, going to light sleep or stage N1 sleep, a heavier form of sleep, and very quickly dropping off into slow wave sleep, otherwise known as non-REM sleep. And then after some time, a person goes into REM sleep. And so this cycle continues. Every 90 or so minutes is a conventional sleep cycle where a person cycles from light stages of sleep N1 to slow wave sleep to N3, and then finishing off with some REM sleep. And this cycle again repeats itself over the course of the night. There are some changes. More REM sleep is usually seen in the latter half of the night, for example. But what I want to sort of illustrate with this hypnogram, or this concept of how we stage sleep, is that it should normally be a cyclical pattern following non-REM all the way to REM sleep. That happens every 90 minutes or so. First half of the night's dominated by non-REM sleep, the second half by REM sleep. And the fact that a person will often wake up for little brief periods during the nighttime, this is actually pretty darn normal for various reasons. And so small bouts of wakefulness during the nighttime are not necessarily abnormal. Now, sleep, whether or not a person has Parkinson's disease or not, sleep normally changes as we age. And unfortunately, like most things in life, it's not something that gets better. It's something that changes in ways that we think are not helpful. What we notice over time is that as people age, that for everyone, it takes longer for them to fall asleep, which might be a function of the fact that those two processes, process C and process S, those forces that keep one awake and sleep don't function as efficiently as they used to. The total time that a person is asleep throughout the entire night decreases because there's more episodes of wakefulness during the nighttime, and so thus the amount of sleep efficiency is reduced. Um, and the total amount of so-called slow wave sleep, or N3 sleep, which we again consider the most restorative form of sleep, tends to drop off over time as well. Also, as a person gets older, they start to accumulate other sleep disorders, things like insomnia, restless legs, or sleep apnea, which we'll talk a bit about. So that's just normal aging on its own. The sleep cycles and the amount of sleep and the quality of sleep are going to change over time, unfortunately. Well, how does this change in people who age and also have Parkinson's to boot? So here it is, again, is another hypnogram. Just an illustrative example of a 60-year-old woman who doesn't have any sleep concerns, but underwent a sleep study. And again, we see that the cycles of sleep are present. Again, we see these roughly 90-minute cycles. It's a bit messier, but we see that there's more times during the night that this individual is awake for short periods of time. But overall, that this person doesn't have any sleep concerns, and that during the daytime they're awake for the full length of the day. And we contrast this with a man who's had only fairly mild to maybe moderate Parkinson's disease, and you see that already there's a few things that might jump out to you. The fact that there's seems to be a less slow wave sleep in this individual. The sleep, although this individual was up often during the nighttime, look how much more fragmented the sleep quality is throughout the entire night. So there's less slow wave sleep, less restorative sleep. There's more sleep fragmentation during the nighttime. And then this individual in particular has a lot of daytime sleepiness where they keep falling asleep during the daytime, whereas this person who has no sleep concerns, well, and though roughly the same age, seems to be doing quite well. And so not only are there changes in the sleep architecture as one normally ages, these things are compounded even worse in Parkinson's disease. And so broadly speaking, the amount of time spent asleep is roughly the same, but the quality of the sleep and the sleep efficiency is a lot lower. Let's switch gears a little bit and talk about this very specific sleep disorders in Parkinson's disease. And there's certainly many. Um, First off, again, as I highlighted at the very start of the talk, is that non-motor symptoms and sleep in particular are very, very common. And as I mentioned before, we have reasonably good treatments for most of the motor features of Parkinson's disease. It's the non-motor features that can be much more tricky to try to manage, and sleep is one of those sorts of things. So we know that sleep issues are a prominent feature in at least a third of people, but we know that well over two-thirds, and honestly, that's probably an underestimate, of people with Parkinson's disease will have some sort of a sleep-related issue. And the reasons for this is, as we sort of mentioned, is that normal aging is part of it, but not all of it. As we already talked about, sleep and wake cycles, those circuits that promote sleep and promote wakefulness, they don't work as they normally should in people with Parkinson's disease. People with Parkinson's disease clearly have Parkinson's disease specific features that disturb the sleep themselves. Some of these are motor features, like akinesia or bradykinesia, slowness of movement that might make it more difficult for you to get comfortable or turn in bed in the middle of the night. Tremor might prevent a person from falling asleep if it's bothersome enough. And of course, there are non-motor symptoms as well. Nocturia means having to get up to pee during the night. We know people with Parkinson's disease have to pee a lot, quite often, because that part of the body doesn't work as efficiently as it used to. Mood disorders, anxiety is very common in Parkinson's disease, as are other psychiatric disorders like depression. And of course, in certain people, they might develop, especially at later stages of disease, psychosis or hallucinations. Medications that are very specific to Parkinson's can clearly affect sleep-wake cycle, which we'll talk about. And there are underlying probable genetic factors that maybe predispose people to develop Parkinson's and may also predispose them to have sleep issues. Looking at some of the very specific sleep disorders that we commonly see, insomnia is pretty darn common, as is excessive daytime somnolence or daytime sleepiness, which can be very disabling and very troublesome in people who have Parkinson's disease. There's other sleep disorders that we'll talk about, like restless legs syndrome or PLEMS, which is periodic limb movements of sleep. They're related concepts, as well as sleep-related breathing disorders, sleep apnea being actually quite prominent, which we'll talk about. And then the parasomnias like REM sleep behavior disorder. We'll go a little bit one by one quickly through each of these concepts or each of these sleep disorders and how we define them and ways that we can consider treating them as well. So I'll say, broadly speaking, this is an observation that many have made and has been studied, is that most people with PD, and again, that doesn't describe everybody, but most people usually don't have too much trouble falling asleep. Your classic, when most people classically think of people having insomnia or being insomniacs, they think of people who just, go to bed, shut off the lights, and they simply cannot fall asleep. They're tossing, they're turning, it's been hours, and then maybe finally they drop off after some time. But the people with Parkinson's disease are a little bit interesting in that usually falling asleep is not necessarily the issue in most of them. The problem is often staying asleep or what we call middle insomnia, middle of the night insomnia, where a person falls asleep fine, but then they wake up for whatever reason during the nighttime, and they simply cannot get back to sleep for the life of them. And so this is, I think, a very important concept to highlight because often a lot of the advice for most insomniacs, those people who have difficulty falling asleep in the first place, might not necessarily apply if you have Parkinson's disease, because often falling asleep is not the problem, it's staying asleep that's the problem. And so people with Parkinson's disease have very unique challenges as compared to many people with insomnia who don't have Parkinson's disease. And so as I mentioned before, many of these individuals end up falling asleep early and then waking up very early in ways that are very inconvenient to them, although the total amount of time that they sleep might actually be normal. And so to reiterate, the key message is that this type of insomnia, middle of the night insomnia, is something that most people with Parkinson's disease will suffer from rather than initiation insomnia or falling asleep in the first place type of insomnia. And so what are things that we talk about, or what are things that a person can do in order to help with this? Now, sleep hygiene is a concept that's very frequently mentioned. It's not a great term, but it's the one that's commonly used, and that involves ways of trying to improve ways of trying to improve the efficiency of sleep based upon your sleep environment. And so, again, I want to reiterate some of the conventional advice for insomnia may or may not apply to people with Parkinson's disease because of these two types of insomnia that can be different, initiation versus so-called middle insomnia. And so things that you can try to implement in yourself, that some of which might be easy, some of which might be a little more hard, but these are the sort of concepts we talk about with sleep hygiene, is that the first one would be don't take too many naps late in the day. The conventional advice in insomnia in general is to avoid napping completely, but I think people with Parkinson's disease have very unique challenges and do and can benefit from short naps so long as they're targeted. 20, 30-minute targeted naps in the middle of the day might make that person feel a lot better during the daytime and might not necessarily impact the sleep that they get at night. Caffeine only before 4 p.m. I like caffeine, and I think caffeine can be very helpful in people with Parkinson's disease, both in terms of alertness, but also in terms of their motor function. And the conventional wisdom in people who have initiation insomnia is no caffeine after 12 p.m. or at noontime, because caffeine sticks around in the body for quite a bit of time. But I think for people with Parkinson's disease, you can be a little more liberal, and you can have that afternoon, early afternoon coffee, because it might keep you awake up until around 9 or 10 o'clock when you actually want to go to sleep. We always want to avoid a lot of alcohol for a lot of different reasons, but we know that too much alcohol might put you to sleep, but it won't keep you asleep. Even if people who don't have Parkinson's disease don't necessarily have insomnia, we know that alcohol can wake people up in the middle of the night. So it's not something that you want to rely on to help you fall asleep, as some people do. Exercise, exercise, exercise. Again, we have nothing in our arsenal today that will slow the progression of Parkinson's disease, but we do know that exercise is one of the things that does seem to change outcomes, reduce the progression of Parkinson's disease over time. And yet again, exercise is good for yet another thing, and that seems to be regulating sleep cycles and promoting sleepiness during the nighttime. Daylight exposure is another thing that has been heavily studied, and there actually has been some actual genuine trials looking at light therapy, bright light therapy, which is a very relevant concept in Alberta and certainly in Edmonton, where we're quite far north and we don't necessarily get a lot of light during the winter months. Light is that thing that stimulates process C, the wakefulness drive. And so bright light during the early morning, during the daytime, is very helpful to promote wakefulness. Conversely, we don't want to have light exposure to ourselves during the nighttime, because that keeps blaring a signal into our brains to keep waking up. So bright light therapy or bright light exposure during the earlier parts of the day, maybe even coincident with exercise, and yet dimming the lights, avoiding screen time during the nighttime to help promote that normal sleep-wake cycle. There's other sorts of things that may or may not help. Again, peeing during the night, so-called nocturia, is a frequent issue that could have many different reasons. And sometimes drinking too much fluid may or may not be the solution. And of course, the problem with not drinking enough fluid during the daytime is it might make your orthostatic hypotension or might make your constipation worse. So it's not necessarily easy to implement. Avoiding stress during bed is often helpful, right? The conventional example I give is that, I was, before I started as a staff neurologist, I was in school for about 40 years, which means I had about 40 years worth of tests and exams to study for. And I would never sleep properly the night before. I would wake up spontaneously every hour because I was worried I was going to miss the test. This is, I'm sure, a very common experience for many, many, many people who have a very stressful sort of event. And so easier said than done, but we know that stress is one of those things that's going to alert the mind. And there are ways that we need to be able to combat that stress: mindfulness techniques, meditation, relaxation, ways of trying to avoid the amount of stress that we have to help us sleep better during the nighttime. The other issue that can sometimes be helpful from a sleep hygiene perspective is the concept of don't stay in bed if you can't sleep. The way that we often describe this in people who have insomnia and stay in bed and struggle to fall asleep or stay asleep is that it's like trying to fight a grizzly bear and trying to sleep at the same time. You're never going to win that sort of battle. And so the conventional advice is, if you've been in bed for some time and you feel like you're not going to fall asleep, get up. Go to a room with dim lighting, do something boring or distracting for 15 or 20 minutes or so, and then go back to bed and try again. The fundamental concept is you never want to associate your bed as a place of worry and insomnia. You always want to associate your bed with only sleeping, not frustration. And so the concept is don't fight the bear. It's not going to be helpful. There's other things that you can do with with the doctor that's following you for your Parkinson's disease. And a very common thing that's very important, or a very common reason that people might have middle insomnia or wake up during the night and can't fall asleep is, well, are my Parkinson's disease medications wearing off? Is right. We know that motor symptoms can get worse during the night, potentially because, well, you've been off your medications for a fair bit of time, or at least many of you who are still taking pills, pills and such. And so we know things like tremor, stiffness, pain, or restlessness. Those are things that can keep you awake. If that seems to be the case, there's a few strategies that we can try, and they're not always successful, but certainly they're worth to try. Sometimes levodopa right at bedtime is helpful in the so-called CR version or continuous release version. Sometimes helps people stay asleep. There's other long-acting medications that could be considered as well. There's verticatine patches and the like that maybe could help get people through the day. One thing that we often try is leave it open in the middle of the night, right? So if you wake up and that tremor or rigidity is preventing you from getting comfortable and getting back to sleep, sometimes taking a half tab of levodopa, chewing it so that it gets absorbed maybe a little bit quicker. Sometimes that's enough to help a person fall asleep. So these are all things that you can talk with your treating neurologist about. Advanced therapies. Again, we use advanced therapies, things like DBS surgery or duodopa or Vyalev. All of these we consider advanced therapies. There is now increasing work looking at, do these therapies actually improve the quality of sleep? That's not why people undergo these advanced procedures. They have very specific criteria. Um, you know, Broadly speaking, poor off time or too much dyskinesias. Um, but we do know that as a concept, it's possible that these advanced therapies might help. Although certainly that's not the target, and certainly it's something that's not completely well studied. Other things that to follow up with your training neurologist would be some of the other non-motor symptoms that I mentioned. So urinary frequency is super common during the nighttime. There's many reasons that might be, and sometimes we can do things to try to treat it with medications or other things. Pain is also a very common issue and might not necessarily have a good solution, but at least there are a few things that could be tried. And depression and anxiety. Anxiety especially is one of those things that just keeps you awake, certainly in the middle of the night. And there are some things that we can do to try to treat those. What about other medical issues that are not even related to PD, right? As everyone gets older, age is a very common risk or a very important risk factor for Parkinson's disease, and age is also a common risk factor for literally every other disease for the most part. And so there's many other medications that can keep you awake. Some of them might be related to the Parkinson's disease, like amantadine or selegiline, we know might keep a person awake during the nighttime. And some of it might be completely unrelated to Parkinson's disease. And this is where things get tricky. We know certain heart medications, certain antidepressants, certain other medications that a person needs to be on for their other diseases. Sometimes those can interfere with sleep quality or can cause insomnia in and of themselves. And then we'll talk about other sleep disorders, sleep apnea being a very common culprit that's keeping a person asleep. A very quick mention about sleeping pills. I don't often prescribe them. But it's something that many people are on for one reason or another. One concept again that I want to get clear across is that my learning was always that it seems to treat the wrong type of insomnia. Again, the problem for many people with Parkinson's is not falling asleep; it's staying asleep. And many of these medications might help you fall asleep, but might not help you stay asleep. So the short-acting ones probably won't help too much. The longer-acting ones might help, but then give you daytime drowsiness or cause falls and those sorts of things. We worry about habit forming. The benzodiazepines or anything that ends in azepam, like temazepam or clonazepam, or otherwise known as Ativan, Valium, those sorts of things. Those ones can certainly be habit forming, can cause, and probably in the longer term can cause cognitive issues or falls and imbalance. And so they're a very tricky class of medications to take safely. And of course, coming off them, you can often get a horrible rebound of insomnia. There may or may not be safer options. Melatonin is very commonly thought of or given. Melatonin being a very natural hormone that your brain produces, and for some people can help them fall asleep. In Parkinson's disease specifically, the amount of melatonin that your brain is normally supposed to be making is actually not is actually quite poor. Certainly as everyone ages, the amount of melatonin being produced is not what it normally used to be, but it's compounded in Parkinson's disease, and we think that melatonin helps more in people with Parkinson's disease than other people. There's a lot of Z medications or Z medications, opicone, azopicone, zolpidem. They all have somewhat similar mechanisms. And again, in my experience and in the experience of people with Parkinson's that I speak to, your mileage really varies. For some people, it's helpful, but it's only for a limited time, and then just doesn't seem to work all that well. And there's always questions about the quality of the sleep itself. So even if you get to sleep, is the quality of the sleep any good? Are you actually more rested during the daytime? It's pretty darn variable, unfortunately. Now, there's a lot of newer agents on the market. These are called dual orexin antagonists. Ones that you might have heard of are things like Dayvigo or Qvig. Whether or not they've not necessarily been specifically looked at in Parkinson's disease itself. They've only been looked at in the general population. And these are things that can always be considered, but they're the newer kids on the block that are touted to have fewer side effects. Part of my thought though is that because they're newer medications, we don't know what the longer term side effects are necessarily. I'm going to switch gears to REM sleep behavior disorder as another common sleep issue in people with Parkinson's disease. Very, very, very common issue in Parkinson's disease. Um, um, yeah, I mean, essentially that. So we classify REM sleep behavior disorder or RBD as a parasomnia. Parasomnia just means a behavior that occurs during the middle of the night. In this case, it involves two different functions. One is abnormal behavioral release during REM sleep. So again, REM sleep is where we do most of our vivid dreaming. And normally we should be paralyzed during that time because we don't literally want to be acting out our dreams and fighting that tiger that we're dreaming about. But people who have Parkinson's disease or at high risk of developing Parkinson's disease, that ability to stay completely paralyzed during REM sleep is lost, or it's not functioning as well as it used to. As a consequence, a person is going to break free of that paralysis and actually start to fight the tiger in real life. What we see on a sleep study is a concept called REM sleep without atonia. I'll just show you, just for maybe for interest sake, what a sort of sleep study is and how we diagnose it. So this is an individual who's in sleep. These are electrodes that cover the eyeballs over here, and these are called rapid eye movements. This is REM right here. The eyes are sort of ping pong balling during this stage of sleep over the sort of 30-second stretch. We have an electrodes on the chin, which measures the amount of muscle tone. And this should normally be a beautiful flat isoelectric line during REM sleep, implying that the person is paralyzed. But in this individual, we see a whole bunch of abnormal signal that simply should not be there. And so that's how we diagnose REM sleep behavior disorder, a credible history of a person acting out their dreams, and this very key physiological abnormality that we see on a sleep study. How prevalent is REM sleep behavior disorder? Again, I alluded to, and as many people might already know, is that many people who don't yet have Parkinson's disease or Parkinsonism might actually start acting out their dreams 5, 10, 20 years before they ever develop a Parkinsonian type of tremor. And if you look in the general population, especially in those over age 50 or 60, we think about 1% of people are walking around who do not have Parkinson's disease yet, but do have this concept of REM sleep behavior disorder. In terms of people who have so-called symptomatic RBD, these are individuals who have Parkinson's disease or other diseases that are associated with RBD. And so how many of those individuals act out their dreams at night? It's a little bit hard to tell in Parkinson's disease because we often don't put people in, we don't ask people to undergo sleep studies in many cases, but we sort of assume that it's probably over the lifetime of a person with Parkinson's disease approaches about 50%. And as I alluded to before, about a quarter of those people had RBD symptoms even before they ever were diagnosed with Parkinson's disease. People who have dementia with Lewy bodies, it's extremely frequent, approaching 90% of people, similar in people who have multiple system atrophy. And there are certain reasons why that should be as compared to people who have Parkinson's disease, which we won't go into. More as an aside, narcolepsy, which has absolutely nothing to do with Parkinson's disease, but narcoleptics actually have a REM sleep behavior disorder for a completely different reason. It's not always injurious, but this is the sort of classic story that we get. For example, a 77-year-old man dreamt he was catching a football, and he jumped out of bed and he developed this big bleed on his brain because he smacked his head against the dresser. 5 years later, he was diagnosed with dementia with Lewy bodies. And so injury in REM sleep behavior disorder is super common. At least half of people with RBD are going to report an injury. And the poor bed partner or the person that you're sleeping next to, that is often a person that will get the brunt of a lot of these injuries. Some of these can be quite serious injuries in some cases. If you really look though, it's not always violent behaviors, right? Because we dream about everything, but it's the violent behaviors that are often noticed because that's what sort of brings people to attention. Striking out, hitting themselves, hitting their poor bed partner, and those sorts of things. Treatment options in REM sleep behavior disorder is a huge topic. But the bare bones of it is that a large, well-designed, randomized controlled trials, the gold standard for proving whether or not a treatment works, they are scarce in REM sleep behavior disorder for a ton of reasons. One being is that it's not necessarily easy to get to have a perfect diagnosis of REM sleep behavior disorder, because in order to do so, you have to do a proper sleep study. And so that's not always done, especially in Parkinson's disease. There is a ton of natural symptom variability in how bad a person's RBD symptoms are. It varies night to night, week to week, and over time, we suspect that it seems to get better in most people, but honestly, it's an understudied topic. And the real issue is that whether or not a drug works. Well, we have to have an outcome, and the outcome in most of these drug trials or therapy trials is based completely on subjective reporting, usually by the person's bed partner, right? So, and that bed partner is, asleep for most of the night, right? So it's a little bit hard to study. Now, there are a lot of medications that we think seem to work, although either trials haven't been done or the trials have been inconclusive, but things like melatonin seem to work. Clonazepam is more powerful. It's a benzodiazepine, as I mentioned before, and it can be quite effective, but it can come with side effects, unfortunately, especially as one gets older, and those tend to be cognitive or daytime sleepiness and the like. There's newer evidence for other medications like pramipexole, which is a dopamine agonist, or rivastigmine, which is commonly used in people who have cognitive issues in Parkinson's disease. They may or may not help, to be honest, and things like rivastigmine sometimes make bad dreams even more vivid. So it's not necessarily easy. There's a whole lot of other things that can be considered that have very poor evidence behind them, but there's a whole list of things that we sometimes try in the treatment of REM sleep behavior disorder. What's very important, though, is that if all these medications don't do anything, there are certain things that a person can and should do if they have REM sleep behavior disorder. And the name of the game is always prevention. We don't want to cause an injury in any of these cases. And so those are non-pharmacological measures. Some people need to stay in separate beds or separate rooms, large pillows, padding, removal of sharp or dangerous objects, having a bed low to the ground, even installing a bed rail to prevent people from rolling out of bed are important. And in fact, management of other comorbidities like depression, sleep apnea, are actually pretty important. In this study, not to go over all of the details, but this was a group of people who had some degree of obstructive sleep apnea. The people in blue, all of these individuals had a decrease in the number of RBD events when their sleep apnea was treated with CPAP. There's also other triggers that we think about, and certain things seem to make RBD events more likely. I mentioned stress before as causing insomnia, but high amounts of stress prior to sleep also seems to trigger RBD episodes, as does fatigue, even innocuous things like watching TV before bed. These sorts of things might cause it. Again, these things are a little bit hard to study. I'm not saying definitely watching TV before bed is going to cause it, but there does seem to be these sorts of associations. And so there are environmental things that you might be able to figure out that seem to trigger RBD events that you might be able to do something about. Briefly, I'll mention restless leg syndrome. That's an urge to move the legs. It's often an uncomfortable, unpleasant feeling that a person gets. It's staying at rest or lying down makes the urge much worse. Getting up instantly improves the symptoms, and there's an evening or nighttime predominance of the symptoms. There's many different mimics, but we know that people with Parkinson's disease often have restless legs. Restless legs is often a problem of dopamine regulation, and of course, Parkinson's disease is also a problem of lack of dopamine, and so the two things often come together. There's a lot of treatments that one can consider that maybe we don't have time to go over because it's a complicated subject, but it is to say that there are certain medications that can be helpful. And there's a lot of non-medication things that are important to look at. One of the things is try to remove any of the, if possible, any of the other medications that can make it that can aggravate RLS symptoms. Common ones are things like caffeine or certain antidepressants might make restless legs worse. And there's a whole a host of other things that can be done, like massages and stretches and walking. Exercise is always important, improving sleep hygiene and targeting other sleep disorders. Sleep disordered breathing. So the archetype or the archetypal sleep disordered breathing is sleep apnea. And so sleep apnea is super common in the general population, probably not more common in Parkinson's disease, but as a function of being very prevalent in general, many people with Parkinson's disease will also have sleep apnea. Sleep apnea, as a very basic concept, is normally as we're sleeping during the nighttime, air is flowing in and out of our nose and in our mouth as we breathe. But in some people, they have floppy airways. The airways transiently close off, and so air doesn't quite get into the lungs as it normally should. This we consider this a transient decrease in airflow, and that leads to either two things happening. One, you can have lack of oxygen to the brain that can happen periodically, multiple times a night, and or that can cause a person to wake up during the nighttime. Not necessarily to full consciousness, but enough that the actual sleep itself is broken. Here's a whole host of risk factors that we associate or that can point to a person having sleep apnea. I want to stress as well that snoring may or may not be caused by sleep apnea. Many people with sleep apnea don't snore, in fact, but they often have daytime tiredness or sleepiness. They have higher blood pressure that's hard to control. Their bed partners can witness them stop breathing during the nighttime, and there's also other physical features if they have a higher BMI, if they're older, and especially if they're male. Here's again a hypnogram or a bird's eye view of a sleep study of what I'm talking about. And maybe just focus on the top line here, where again a person is with sleep apnea is awake, they fall to sleep. But look at all of these times during the nighttime that are punctuated by arousals. Every time that they have a sleep apnea or an apneic type of event, they're jolted out of sleep and they're waking up throughout the entire night. And then again, we see these big dips in oxygen. Your oxygen saturation should be 90% or so throughout the entire night. And these are times where the individual has these very dangerous low dips in their levels of oxygen, which certainly cannot be healthy for the brain over a long period of time. If you treat that person with CPAP, look how much better their nighttime goes. Barely any times during the night when they wake up. And the oxygen saturation initially was not great because it was taking some time for them to adjust the settings of the CPAP, but for the rest of the night, looks quite beautiful. Why do we treat sleep apnea? Well, I often distinguish them between short-term benefits. So we do get, in most people, better sleep quality, less daytime sleepiness, better mood, better cognition. And then there's longer-term benefits. We reduce the risk of things like heart attack, stroke, high blood pressure, dementia, and a whole host of other things. One other concept is that there's a frequent misunderstanding of what so-called mild sleep apnea is. Many people will undergo some sort of a sleep study from somewhere that says that that their AHI or apnea-hypopnea index is 10, which is considered mild, and so cannot possibly be the reason why their sleep quality is lousy or why they're sleepy during the daytime. Honestly, mild, there's a very poor correlation between this concept of AHI, apnea-hypopnea index, and daytime sleepiness, as well as a whole host of other symptoms. And so just because a person has mild sleep apnea, often it's still worth treating if it's felt by the sleep specialist that it might be contributing to daytime sleepiness. Why we also treat sleep apnea in Parkinson's disease. There's newer evidence coming out. This from, for example, from McGill. This literally just came out, I think, last month or so, that people who have Parkinson's disease and sleep apnea, if you treat the sleep apnea, there does seem to be measurable benefits in delaying reduction in cognition, in improving motor symptoms during the daytime as well. And why that should be is not fully understood, and we probably don't have time to go through it. But yet another reason why it's important to if there's sleep apnea, to at least consider treating it, because there may be measurable impact upon a person's cognition as well as their motor symptoms. The way that we treat sleep apnea, for some people, it's just a matter of being in the right position. Weight loss, if you have a higher BMI. Dental appliances can be considered, but they're super expensive. Surgical treatments we rarely perform because they have to be very select cases for it, but the main treatment is CPAP, a device, a mask, or something like that that blows a continuous stream of air at a constant pressure, keeps that airway open, allows a person to sleep during the nighttime. The last thing I think I have time to talk about is excessive daytime sleepiness, which is an inability to remain awake during the daytime, a very common issue in Parkinson's disease that can be devilishly hard to study despite its prevalence. Sleep can sometimes occur unintentionally. You can get what we call a sleep attack. Um, Now, it's a little bit hard to study because the way that we measure sleep is various different ways, which we won't get into, but we haven't clearly defined a threshold of sleepiness that we would consider to be excessive, at least not at this time. But we do know, as I said before, that excessive daytime sleepiness or daytime sleepiness is super common. In fact, about 10% of people will have excessive daytime sleepiness at time of diagnosis, and it only gets worse over time as a person has Parkinson's disease. Um, the consequences of daytime sleepiness are obvious, but also measurable, right? But it can increase depression, worsen anxiety. It can worsen cognition, as everybody, as anybody who feels sleepy during the daytime knows. It's hard to make rational decisions if you're sleepy or sleep deprived. And there can actually be measurable impact on things like driving. So in individuals with Parkinson's disease, 50% were involved in a motor vehicle collision over the preceding 5 years. And many of the time, they're more likely to have actually caused the motor vehicle collision. And so the vast majority of these individuals are individuals that had a high propensity for sleepiness. There's lots of causes for sleepiness in Parkinson's disease, and it's not always easy. As I often tell people, there's more than one reason why something happens, and so often it's a multitude of things that sort of come together that can make a person sleepy. In Parkinson's disease, sometimes it is a question of poor nighttime sleep, but that's usually not the only reason. As I highlighted before, there's a lot of treatable or potentially treatable primary sleep disorders like sleep apnea or restless legs, or even REM sleep behavior disorder that might improve daytime sleepiness if you treat them. Parkinson's disease medications, almost all of them will cause a person to be sleepy. And this is just a thing that gets worse over time because as a person's Parkinson's develops further, we need to increase the amount of dopamine we give them to compensate. But that dopamine itself, unfortunately, can lead to increased sleepiness. And then as I started to talk off by saying this, it's an intrinsic manifestation of the Parkinson's disease itself. Parkinson's disease, as that synuclein spreads throughout the brain, it just damages the structures that regulate sleep and wake, and that's why it can be quite hard to treat. What are things that you can do? Non-medications, which I highlighted or alluded to before, targeted napping, I think is probably okay for most people, especially if it's not disrupting a nighttime sleep. And especially if you limit it to discrete episodes of the day where you can get maximum benefit. Consistent light exposure during the daytime, reducing light exposure towards the end of the night might be helpful as well. And exercise always helps no matter what. Medications, sometimes you can actually modulate the amount of dopamine. Sometimes we jack up the dopamine too high during the daytime, and you can work with your neurologist to try to even out those levels potentially, and that may or may not help. Wakefulness promoters, there is variable evidence about whether or not these work. And these are things like Ritalin, for example, which is a stimulant which has been very little studied in Parkinson's disease specifically and probably doesn't help all that much, probably causes more side effects than it really helps. Modafinil has had studies over the years that have just been some say it works, some say it don't. Anecdotally, I'll say that some people on modafinil, some of my patients found it amazing, others did not. So your mileage varies. And there are newer kids on the block like solriamfetol and pitolisant. Now, these are used in narcolepsy all the time, and some have been studied a little bit. For example, in this trial by Vidanovich, which used solriamfetol, which unfortunately didn't notice any benefit with medication. But frankly, these things are pretty understudied. Caffeine, I love. Again, my mentor, Ron Postuma, also loves caffeine. And we do think that it provides possibly a modest benefit on daytime sleepiness, but also seems to actually provide some motor symptom benefit. I think that's all the slides I have. And I'm hoping we have at least time to discuss a few questions. Thank you.
Yes, we definitely have some time for some questions. Thank you. I've got a few in the chat already. So first one is, can sleep disorders and Parkinson's intensify like the motor symptoms or like freezing episodes for, I guess, people with Parkinson's?
If I understand the question, is the quality of your sleep or can sleep disorders, does that influence how bad your Parkinson's symptoms are? And your Parkinson's symptoms could be things like freezing of gait or things like that. I mean, absolutely, right? Let's say you don't even have Parkinson's disease. If you have a lousy night of sleep for night after night after night, you feel wrecked. You're more fatigued, you're more tired, it's harder to do anything. You add on the fact that not only do you have lousy quality of sleep or daytime sleepiness, but you also have Parkinson's disease. Well, it just amplifies things all the more. And so that's kind of what I mentioned before, is that if there are ways that we can improve the sleep, for example, if a person has sleep apnea or restless legs, and we treat that and we improve the quality of sleep during the nighttime, we actually can get measurable benefit on Parkinson motor features like rigidity and bradykinesia, and also non-motor features, things like cognition and depression and the like. Now, would it help a person's freezing of gait? I don't see why not. It's one of those things that's probably not very well studied, but we know that freezing of gait, we don't know 100% why it happens, but we know that poor cognition or reduced alertness are one of the things that can trigger a freezing of gait event. For example, we often tell people who have freezing of gait that if they're walking, don't talk to whoever you're walking with. Either do one or the other. Either walk with that person or stop and then talk with the person, because that cognitive distraction of holding a conversation is going to trigger a freezing of gait event. So you can sort of extrapolate from that and say that, well, if that person is suffering cognitive difficulties because they had lousy sleep over the last few nights, well, that's just going to make a freezing event probably more likely. So broadly speaking, treating sleep as best we can, and it's imperfect, I'll admit, but doing our best to try to improve sleep often can have potential measurable impact on both motor and non-motor symptoms of Parkinson's disease.
Thank you. Got another one here. So I have very vivid dreams every night. They say they do not act them out, but that it's almost like they live like another day through their dreams. They're very realistic, very colorful, include people they know, and they wake up tired as if it seems like they physically went through like this actual day or dream. Is this common in Parkinson's to have these vivid dreams, I guess, and feel so tired after, but not be maybe physically acting them out?
Yeah, I'm not sure, right? The thing about REM sleep behavior disorder, as I said before, is that it's completely subjective. It relies either on the person themselves knowing that they had an event because they woke themselves up, or their bed partner is able to describe it. But if you actually look at most people who have REM sleep behavior disorder and you look at them night after night after night, you actually train a camera on them to see what they do. Most
Mm.
of them are actually not doing this the entire night. Most of it is actually very subtle, sort of little teeny tiny increases in muscle tone that are either completely barely imperceptible or quite minor. And so just because a person isn't acting out their dreams every single night doesn't mean that they don't have RBD. The question about vivid dreams is something that comes up frequently in Parkinson's disease. I don't always know why. Um, Common culprits though are medications for many people, not everybody, but common things that can increase the amount of vivid dreams that a person has can be medications. Certain culprits are things like antidepressants can do it. Cholinesterase inhibitors like donepezil or ribostigmine, those things that we use for cognitive alerting. Sometimes that does also give people vivid dreams. Melatonin, sometimes, again, your mileage varies, but some people say that the melatonin can increase the amount of vivid dreams. So it's not always clear what's causing them. But there might, again, just be an intrinsic reason that people with Parkinson's disease have more vivid dreams than others. I would speculate that, if a person's sleep quality is crummy, I would hazard that it's not necessarily the fact that they have vivid dreams that's causing it. Many people with RBD actually seem to sleep okay during the nighttime. So just because a person acts out their dreams doesn't mean the sleep is necessarily disrupted. There might be another underlying reason why that person feels crummy. Whether or not that's directly related to vivid dreams is a very interesting question, but hard to be definitive about.
Thank you. I've got one here about sleep apnea. So does it increase someone's risk for strokes or TIAs?
Excellent question. Yes, but as always, there's always caveats, there's always provisos, there's always, well, what about this case? But I'll say, broadly speaking, how I counsel people about why I want to treat their sleep apnea. As I said before, there's obvious upfront reasons. I want to improve the quality of your sleep. I want to reduce the amount of daytime sleepiness you have, and maybe there'll also be a measurable impact upon your Parkinson's symptoms, motor or non-motor. But then I also talk about longer term benefits, and these are things that are less tangible, right? For example, conceptually, many people have high blood pressure, but they don't feel they have high blood pressure. But the doctor says, take your blood pressure pills, will reduce your blood pressure. They take the blood pressure pills, but they don't feel any different. Yeah, that's true. They don't feel any different, but by taking your blood pressure medications, you reduce the risk of stroke in the future. And so sometimes that lack of tangible, obvious benefit is tricky. But people have studied this, especially in stroke, because we know that many people, about two-thirds of people who have had a stroke have sleep apnea. And so the obvious thing that people looked at is, well, what if we treat the sleep apnea? Do we reduce the risk of another stroke from happening? And for years, they tried to study this. They tried to look at people who already had a stroke and have sleep apnea. What would happen if we treated that with CPAP? And for many years, the result was there was no impact. Whether or not they got another stroke, it didn't matter if they're on CPAP or not. And so, the initial studies done in 2000s and early 2010s were that yes, many people with sleep apnea have strokes, but it seems like treating with sleep apnea doesn't reduce the risk. But then they went back and looked at the data more carefully, and they also did newer studies, and they noticed that many people can't seem to take CPAP. Yes, they're prescribed it. Yes, maybe they use it for an hour or half an hour during the night, but then they just rip it off during the night. If you look at the people who had a stroke and sleep apnea and use their CPAP throughout the night, or at least a bare minimum of 4 hours, if you use your CPAP, you do reduce the risk of another stroke. And so those earlier trials were probably incorrect because they were looking at all people and we're not looking carefully enough about how much those people actually use their CPAP mask. So final sort of message on that is yes, we do believe that if a person has sleep apnea, and especially if it's moderate or severe, treating it with CPAP or at least treating it in some way probably does reduce the risk of things like heart attack, stroke, and also may reduce the risk of things like Alzheimer's disease or relevant to Parkinson's disease, Lewy body dementia, and the like.
Excellent. Thank you. Another kind of follow-up one here on sleep apnea. Will levodopa help reduce sleep apnea in people with Parkinson's?
Unfortunately, probably not. Sleep apnea is a structural problem in most people. The airways are a little bit floppy. They, for whatever reason, floppy and they close off, and that's why air is not flowing through. So the levodopa is unlikely to help that, unfortunately. Yeah.
Yeah. Um, I've got a couple more here. So does the REM sleep behavior disorder progress over time, like get worse over time?
Yeah. Yeah. It's such an important question and such an understudied question. I tried looking this up a few months ago because I had the same question, and I looked into it before and didn't find an answer, and I was wondering, well, maybe I missed it, or maybe someone published a new study that gives us the answer. We don't know.
Hmm.
All I can say is that it's very anecdotal, and I found like one study from about 5 years ago from a small group in Korea that looked at people over time. And the general thought, and this is on a population level, it does not work for the one individual in front of me, but the general thought is that the symptoms of RBD seem to get better over time, as in they become less frequent or less violent. But honestly, I don't know A, if that's true, and B, I can't predict that in any one individual. It's hard to study, to be honest, and we simply don't have that data.
Hmm. Thank you. I've got a couple other ones here. So can Parkinson's affect one's, it says biological clock, but I'm wondering if they mean circadian rhythm for sleep there.
Yeah. Yeah, clearly. There's so many more slides and stuff that I could have talked about or tried to jam in there. And this is an area of intense study. So the biological clock, yep, you can consider circadian rhythms to be a biological clock for sure. And one of the most important hormones that help regulate that biological clock is actually melatonin, right? It's a natural hormone that your brain normally produces, and that helps entrain, or that helps in part explain these sorts of sinusoidal, changes in circadian rhythms. We know that people who age, the amount of melatonin that they produce is irregular, but we know that people in Parkinson's disease, especially, the amount of melatonin that they normally produce is not this at the same level as a person who does not have Parkinson's disease. And so, as a consequence, I mean, that's just one of many examples of circadian trouble with the circadian rhythm. But we know that in Parkinson's disease, those parts of the brain that regulate that clock, they don't work very well. They are in the same way that other parts of the brain are damaged. They are, certainly can be damaged in people with Parkinson's disease.
We've got two more here. So one is about so you mentioned like sleep hygiene a little bit
Mhm.
earlier. So they're wondering if listening to like a quiet story or like a sleep story or sleep music is an issue with sleep quality.
You do you is what I say to people. I don't. There's no one right way to fall asleep, and sleep hygiene is, again, we try to put people into boxes and they don't always fit everybody. The conventional thing that I would say is that if it's helpful for you to fall asleep and stay asleep, there's nothing wrong with it. Other things I simply just didn't talk about that can help sleep hygiene are things like white noise or low amounts of noise, non-stimulating noise. Like, don't listen to a super exciting detective story. As you try to drift off to sleep, your brain's just going to be too excited to know what happens next. But having like a quiet, soothing sort of voice that drowns out any of the other sort of ambient sound, so white noise, what we might call, making sure the room is as dark as possible, or getting a sleep mask. I use a sleep mask. I love it. Right. Those sorts of things that can sort of numb the ambient environment can be conducive to helping sleep. And so if you find it helpful to fall asleep and maybe even stay asleep, there's nothing wrong with trying it. I would just avoid anything that's too stimulating.
Excellent. Thank you. There's one last one here before we wrap up. So, and is it okay to take sleep ease every night before bed?
Hmm. I'll have to sleep ease. I don't know that
Sleep
one.
ease is a
Yeah.
diphenhydramine
Oh,
hydrochloride
diphenhydramine.
capsule.
Yeah. Yeah. As I, it is so easy for me to sit here and to say, well, these things are bad for you. But I will say that the evidence for these sleep aids is not great. Yes, it'll zonk you out. But that's not always the best way to go about it, because it might zonk you out, but does it actually improve sleep quality? Probably not. And my biggest concern with a lot of these over-the-counter or sort of medications is that they might actually make you drowsy and cognitively not well during the day. Now, it might be if you're 50 years old and don't have Parkinson's disease, maybe that's not as big of an issue. Very different story after you've had Parkinson's disease a dozen years and you're in your 70s. These medications have a more profound effect upon you. Of course, as a neurologist, I work in the hospital as well on the wards a few times during the year. And one of the most common reasons that we think that people have delirium in the hospital is because of medications along these sorts of lines that are prescribed, to either calm them down or fall asleep. So I'm not saying that that's in every case, but we have a pretty dim view of a lot of these over-the-counter sleep aids because we think that the side effect profile of it is probably not worth it. Yes, it zonks you to sleep, but the quality of your sleep is probably not going to be great, and it might cause some side effects. The other issue being is that maybe it's just masking an underlying sleep disorder that hasn't been thought about. It's so easy to just prescribe or just take something over the counter. It's less easy to go a little more in depth and try to rule out other things that might be causing lousy sleep.
Excellent. Thank you. That question actually comes up quite a bit for sleep medication. So thank you for that.
Yeah.
That's all the questions I see in here at the moment, and we're after 11 o'clock, so I don't want to take up too much more of your time or anything, but I just wanted to say thank you for joining us and sharing all of your information and wisdom and that on sleep and Parkinson's. And that for everyone attending, thank you for joining us today. We've recorded today, so if you want to rewatch bits and pieces or anything like that, you're free to do so. It should be up in the next couple of days, but thank you, everybody.
Thank you.
Excellent. Take care, everyone.
Bye now.